Hello and welcome to my channel. Today we are going to talk about pseudomembranous colitis. It is a disease which is caused by Clostridium difficile. Now the overview of the treatment, and then we will talk about pseudomembranous colitis in detail. So the first line treatment is oral metronidazole for 10 days. If the disease is recurrent or if the patient is allergic to metronidazole, then oral vancomycin will be the treatment of choice. So now we will talk about pseudomembranous colitis in detail. Pseudomembranous colitis is a severe inflammation of the colon which is caused by the overgrowth of the Clostridium difficile, typically following an antibiotic use. We will talk about these antibiotics in the next slide. So it is characterized by yellow-white plaques or pseudomembranes, which is the characteristic finding on the endoscopy within the colonic mucosa. So I will explain the pathophysiology with a diagram and then we will come to the text. So whenever a patient is given broad spectrum antibiotics, it will result into decrease in the normal gut flora and will cause a overgrowth of the Clostridium difficile. The Clostridium difficile is one of the organism which is a normal flora of the large gut, but its overgrowth will become a problem. It will start to produce toxin A and toxin B, which will start to damage the colonic mucosa. As a result of damage to this colonic mucosa, there will be development of pseudomembrane. Apart from this, there could be development of ulcers as well as plaques can also develop. So in the pathophysiology, what is important to note is that these antibiotics, which is the clindamycin, cephalosporin, and the fluoroquinolones, they are notorious for causing pseudomembranous colitis. Toxin A and B are going to produce damage to the mucosa, and as a result of this, pseudomembranes will develop. Talking about the clinical features, the patient will develop watery diarrhea, which is often profuse and foul-smelling, in association with abdominal pain and cramping. Patient can also develop signs of sepsis and signs of shock, which include fever, increase in the WBCs, hypovolemia with associated electrolyte imbalance. In severe cases, there could be development of toxic methacolon or perforation, and full-blown sepsis can also develop. So now we will talk about the diagnosis of pseudomembranous colitis. Very first thing is that it is a clinically diagnosed pathology in which the patient who was given recent antibiotic for a long period of time for an established infection, he or she develops diarrhea. In that case, a suspicion of pseudomembranous colitis should be on top of the list. However, in terms of lab, the important things are stool test for the Clostridium difficile's toxin A and B, which can either be performed by ELISA or PCR. This is one of the high yield tests for making up the diagnosis. Rest of the tests are for diagnosing the developed sepsis or developed acute kidney injury or hypovolemic shock. Then we have the imaging. In terms of imaging, CT abdomen can be used to see for the dilated bowel and thickened colon wall. However, again, apart from the lab test, the second most important lab diagnosis is made on the basis of the endoscopy. Endoscopy is specifically done, that is the sigmoidoscopy or colonoscopy. It is going to yield the pathophysiological finding associated with the PMC, that is the yellowish pseudomembrane on the mucosa, with associated ulcers and fibrinous exudate can also be found. So in terms of the treatment, the very first step is to stop the antibiotic, and then we will quantify the patient in terms of the severity. So for mild to moderate disease, oral vancomycin 125 mg QID for 10 days is preferred. But if the patient is having severe or complicated case, then we will have to shift the patient to nail by mouth, IV fluids, oral vancomycin with associated intravenous metronidazole. But if the patient is having a recurrent infection, then the treatment would be fidaxomicin or vancomycin. But recent studies have shown that fecal microbiota transplant can also be of help. But if in some cases, the patient has developed some pathology like perforation or fulminative colitis. In that case, we will have to go directly towards the surgery. That will be the total abdominal colectomy with end ileus. In terms of the supportive care with associated management, we have to rehydrate the patient, we have to correct the electrolyte imbalance, and specifically, we have to avoid the anti-motility agents. Now, in terms of prevention, whenever an old age patient comes with a pathology like of the abdominal sepsis and we are supposed to give them antibiotics, we have to be very precise in using the antibiotics. So, the second important step is the infection control in hospitals, followed by the use of probiotics in high risk cases, though it remains controversial. So, thank you for listening. I hope I have cleared your concepts related to the pseudomembranous colitis. So, thank you very much for listening to this lecture.